Okay. Well, thank you and welcome to this, the first Q&A session. Thank you, Ethan, David and Cinzia, for a tremendous introduction. I think you set out the various principles of harm reduction, some of the intellectual underpinning for compassionate approaches, and also provided a sort of clear insight into some of the barriers, but also the practical benefits that harm reduction can provide. Now, we have got a number of questions, and I am going to start off with one here that goes back to Ethan's presentation, but I'm going to invite everyone to contribute. Do you see a distinction between harm reduction and harm minimisation? The example given here is using your pen cap. So telling Johnny not to suck the pen cap would be an example of harm minimisation. Producing pen caps with holes in them is an example of harm reduction. But I mean, I guess I've worked in areas where when we have used the expressions, have often used them interchangeably, but I'd be interested to know if you do see a difference.
Yeah, no, I really would use those phrases interchangeably as well. I remember going back, to the 90s, et cetera, early 2000s, there was all this debate about exactly what should we use the phrase harm reduction, harm minimization, risk reduction, risk minimization. There were sometimes efforts on the part of abstention-only people to say abstention-only policies were harm reduction. There's been a big battle on that, but I think that as we're making our best efforts to try to advance the philosophy of harm reduction, I think it's more important to stay focused on the core principles and not get so concerned about the specific wording.
Okay. Cinzia, David, do you want to come in on that?
I would agree as well, if I can. And I think that Ethan's presentation about the four meanings of harm reduction gave us such a variety of angles in which you can interpret harm reduction that I would agree. Let's stick to the core principles and do not get involved into differences between harm reduction and harm minimization. Also, the harm reduction approach changes so much according to the ways in which policies change, in which drug use change, in which settings change. So I would also agree that focusing on the core principle is what we really need to do.
Yeah, I agree. Essentially what we're doing is whenever we see risk, we try to reduce it. And that's a really pragmatic approach. We do it, within the confines of empathy, trying to understand what motivates people to be doing what they are. How do we empower them? So I think it's simply a matter of, in principle, we're being very pragmatic in reducing risk wherever we find it. We can call it whatever we want, and we do use some terms that can get some people very upset because it's contradictory to the views they have about how people should behave. But essentially, it's just pragmatic. Call it what you want.
Yeah, let me just add, I just remember going back, there was always this dilemma with the phrase harm reduction or harm minimization. On the one hand, the strength of the phrase is that it's very hard to be against it. Who could be against reducing harm or minimizing harm or risk? On the other hand, and especially in the US context where we think about advocacy and rallying people, reduce the harm, minimize the harm, it's not exactly bold language that inspires people to action. And so that's been the traditional dilemma in advocacy in this area.
I've got a question that leads on from that, and I'm going to direct it at Cinzia to start with, because in your presentation, you spoke about when you began at the European Commission, I think, about how the phrase harm reduction or minimisation wasn't really used that much in policy. And that question's been raised. And I have to say, when I worked in central government, and I've gone back and looked at strategies which historically have been described as being very harm reductionist, the phrase was hardly ever used, and we still hardly ever use it at national level strategy, in national level strategy documents. Is it because, like Ethan's just said, it lacks focus, or are people still slightly wary about the whole term harm reduction at a policy level?
Well, I think that dates back in time where the policies were changing, and it's true that policies of the European Union have changed a lot since the times I was there, I have to say. And the European Union, for a number of years, in the following years, has been a champion of harm reduction. I think it has allowed harm reduction concepts and services and policies to be raised up at a higher level. It facilitated networking of civil societies. It created networks of experts who supported the construction and the fact that we could build harm reduction into drug policy in general terms. I saw it happen, really. At the time I joined the European Commission, it was back in 2001, I think they still did not have a clear idea. But the fact that they started funding some projects which allowed them to see how harm reduction works in practice and which were the benefits of harm reduction made it also into the policy. So allowed the European Union to have a more balanced policy on drugs, which included a number of different angles. And it has remained so for a number of years, I have to say. Maybe less now, unfortunately, but it has been strong and really helped the development of the concept at European level.
You know, if I could just add to that, I think another issue that happened, especially in the earlier years, was that the opponents of harm reduction deliberately conflated harm reduction and drug legalization, by which they oftentimes meant free market drug legalization. And I think it was a powerful effort on their part. It happened very much in the United States and the federal government. It definitely influenced the way that UNODC and its predecessor agency shaped this. It was a little bit understandable. There were prominent people, advocates like myself and others, who were simultaneously deeply involved in advancing basic harm reduction and also engaged in the debates around drug legalization. But none of us were free market drug legalizers or all this sort of stuff. But you could just see these incredibly disingenuous efforts. I mean, some of it was naive, but mostly I think it was informed and disingenuous on the part of major officials around the world, especially US, especially Vienna, really saying, oh, harm reduction is just legalization in sheep's clothing and things like that. And I think eventually that just has faded a lot more, where that's much less of a concern these days.
I have to say, Ethan, you've just answered another question that had just come up there very directly about the problems sometimes between harm reduction being linked to drug law changes. I've got a question here for Dave Sweanor about whether you're genuinely optimistic about seeing a better quality of debate, particularly around tobacco harm reduction, when so many of those involved have such very deeply entrenched positions.
Well, I suppose this can go either way. I mean, when we look at the history of what's happened with technology advancements in reducing risk in other areas, risk reduction usually wins out, often fairly rapidly, and despite the opposition. And I think that if we look at this in the context of a very long history of a whole lot of things where we have reduced risks, the sort of stuff that Pinker has written about in Enlightenment Now. Why the people who are saying they oppose harm reduction would never get in the sort of cars that were designed 30 years ago because they weren't safe enough. They meet in buildings that meet building standards, so they're far less likely to fall down. They're taking trains on rails that no longer have snakeheads, that where the top of the rail comes up through the carriage and kills people. They drink water that's been purified. And amazingly, many of these things were opposed at the time. And again, for these sort of moralistic behavioral types of reasons. So I think the history is on our side, that you eventually win out. But then, as Ethan can tell us, that on some issues, like what's happened with the war on drugs, it can go on for a very long time. It can go, I think we're finally seeing the end of that approach, but it's been decades. And when there's a tremendous amount of political power and money behind those who are pushing a behavioralist, moralistic approach, it takes longer. And that's what we have now. So I think it takes a strategic approach by those who are really promoting health to look at how do you counter this. And I'm optimistic that we can do that, to be able to deal with the arguments that are made against taking a pragmatic approach.
Thank you. Ethan, there's another question directed at you, which says, are you not concerned that harm reduction can actually make drugs more popular and increase the harms there?
I mean, we actually have very powerful evidence on this, right? The argument that was used against needle exchange and better access to sterile syringes in the 80s and 90s was very much that it was condoning and encouraging illicit drug use and drug injection, and in fact would increase that activity. And fortunately, the studies came out showing, no, that's not the case, that making sterile syringes more readily available through legal channels, exchange programs, and pharmacies, in fact, would effectively reduce the spread of the disease without increasing drug use. But I think there is the possibility that at times it may result in a greater amount of activity. It's possible that when one introduces mandatory seatbelts, that people might drive a little faster. It's possible that when one introduces designated driving norms with respect to drunk driving, that people may be more likely to get drunk. It's possible that as we're introducing, in fact, we know as we're introducing e-cigarettes, that there's this all of a sudden proliferation of young people using it. It's why harm reduction focuses not on the cumulative amount of participation or use in an activity, but rather on reducing the cumulative harms. So that effectively, even if use goes, even if harm reduction policies result in the cumulative participation or use increasing by 5 or 10 or 20% or whatever, so long as the cumulative harms of that activity are going down, that's what's really important.
Thank you.
Yeah, I think there's a really nice summary of the issue, I think, in an article that Professor Julia Marcus has recently published in The Atlantic. She's at Harvard Medical School. And she was talking about harm reduction in terms of how we deal with COVID, but brings in the experience in dealing with a whole lot of other issues. And just a quote from that, it says, in all of these examples, a concern about the promotion of risky behavior masquerades as a concern about health. But in reality, resistance to harm reduction is typically a cloak for moral judgments about what constitutes responsible behavior. And I think that's what we're really looking at. So people are not concerned about the harm of the use of a drug or an automobile or a bicycle or various other things people have opposed risk reduction on over time. They're concerned about the behavior itself. You shouldn't be doing that. You shouldn't be using nicotine. Therefore, I will argue about how this could increase risk. But what I really mean is I don't like your behavior, and I'm going to tell you how to live.
Okay. We've actually got one question that leads on from that. Are there any lessons from harm reduction for the way that countries manage the COVID-19 problems?
Oh, I can say I think there's many, because I've been dealing with some of those. There's still this tendency that when you have a problem, that some agencies will, some groups will move to an authoritarian response. It's evidence-free. They want to tell you how to live your life, and they're concerned about behavior, and they'll talk about it as increasing risk. So the way that even here in Ottawa, we had a municipal law passed that to deal with COVID, you were allowed to be in a park only if you were going through that park to get to somewhere else, but you were not allowed to linger, to play, or to engage in any other activity, with fines of $900 for doing it. There was no evidentiary basis to that. It's not based on health, it's anti-health, but it was very much I'm going to tell you how to live your life. And I think any of us who have dealt with vaping, could see how measures like that could come forward. And the Atlantic article is actually talking about some of the issues on COVID, that when people are saying, just go home and stay home, it's not going to work. What can you do that's pragmatic about get out for a walk, but physically distance? That's risk reduction. That's meeting people where they are, and it's viable.
Thanks. Would David or Ethan or Cinzia want to come in on that?
I've been speaking. Cinzia, any comments?
Yeah, I think the danger of the authoritarian approach has very much been there over the last few weeks. We've seen that against the idea that a harm reduction approach is a pragmatic approach. So we need to find ways to get to people where they are at and helping them and empowering them in making informed decisions. And I'm not sure this is what has been always done in the last few weeks from our governments. I also think that the harm reduction lesson is about not leaving anybody behind. So the idea that the lockdown, for example, in the COVID time has affected differently people according to their health status, according to their being rich or poor, according to their having a home or not. Homelessness has been a huge issue during COVID time. So I think the idea of not leaving anybody behind, it's another one which we should look at, and we will have to look at it in the recovery which comes after COVID.
I think we also, I mean, it's a little ominous going forward because, we now look at many of the countries in Asia, some of which have been more authoritarian in their approach, as having been more successful in dealing with COVID, and that therefore maybe the model is that authoritarianism works best, what China did or some other countries. And I think the issue we have in Western, more tolerant societies is that because we can be irresponsible in our policies rather than being pragmatic. And so, I mean, the real challenge in the West, I think, in more open societies is how to rely on fundamental pragmatism and on evidence. It's what David was talking about in the Ottawa context. It's about, yes, these authoritarian instincts kick in. Yes, there's a tendency to avoid, and I think in my third definition of harm reduction, where I talked about harm reduction as policy and reducing both the harms of drugs and the harms of government policies. And similar with COVID, the challenge is reducing the harms of the virus as well as the harms of the government lockdown responses as well, and that one needs to achieve some balance. And balance is something that's somewhat evidence-based, somewhat subjective, but it's obviously something we need to get ever better at. And the more that we can be good at articulating that principle and employing good leadership in order to do that, I think the more likely we will be to succeed in open societies.
Thank you. There's another question directed at you, Ethan, where refers back to your presentation and describing an optimal drug policy. And the question is, which government is closest to achieving that right now?
Well, I mean, the models really have come mostly out of Europe. Sometimes Australia, New Zealand, Canada have shown some real progress as well. But, when I oftentimes think about the three leading pioneers of harm reduction, one was the Dutch, beginning in the late 70s and then the early 80s, first with respect to cannabis reform and a kind of thoughtful decriminalization model, not just with respect to possession, but also the sale. And then being among the first to respond effectively to the spread of HIV among injecting drug users by just, having a harm reduction social service centers where there'd be two buckets and people would be encouraged to toss a dirty needle in one and put another one, and pick up the clean needle in the other. The second model, I think, was very much Switzerland in the mid and late 90s, which introduced, it tried the U.S. law enforcement police model, but then it said, this is not working here. And they then were pioneers with respect to safe injection sites, with respect to prescribing pharmaceutical heroin, with respect to emphasizing a real public health approach. And the third model was really what Portugal did in the beginning of the 21st century, where they introduced basically made a commitment not to legalizing drug possession under the law, but essentially adopting a policy that said we are committing not to put anybody behind bars simply for drug possession, and we're going to treat this primarily as a health issue. So I think those have been three major models, and I'm now somewhat inspired by Vancouver in British Columbia, which has introduced an active discussion around safe supply in the face of a major opioid overdose epidemic. They're trying to be as resourceful and innovative as possible, and that includes making available the sorts of opioids that illicit drug users want, but making them available from legal sources in order to reduce both street criminality and disorder, as well as overdose fatalities and other health ills.
Okay, Cinzia, Dave, you've got anything to add to that?
Again, it's being pragmatic. I mean, what works, do it. And we just have so many examples on so many topics. And I mean, the real exception is like what we're encountering now with alternatives to cigarettes, where people are saying, we'll ban the safer alternatives. And, it's sort of like going back to the mid 1800s and saying, so when John Snow figures out, what's causing cholera, is the response to say, well, we'll leave the handle on the Broad Street pump, but take it off all the other ones. What you do is you go after the high risk stuff. You try to move people to low risk activities. You don't ban them from doing the low risk stuff and force them to do things that are going to harm their health.
Okay. I've got a question that is aimed at Cinzia here. And actually there's two questions which I'll try to blend together. How can those working in countries which have less well-established harm reduction approaches best support colleagues in areas and countries where both services and policies are perhaps less well developed? And then there's a specific question about tobacco harm reduction in sub-Saharan Africa, but perhaps if we deal with the general point about harm reduction in general and then broaden it out to the tobacco harm reduction.
Well, I think I've been spending most of my time in networking work, and networking can happen at different level and at different times. Countries where, speaking about my own country, Italy, for example, where people still do fight for harm reduction to be recognized. The coming together of civil society organizations is very important. So we need to strengthen our network, to strengthen each other, to become more strategic, to learn better how to address the needs of the networks, the needs of the people in the field, and also become more strategic in advocacy work towards our government and towards the international policy environment. So I do think that trying to get any opportunity to network among civil society organizations is a key. It's a key issue, and nowadays there are many opportunities through networking conferences and projects to do this. People witnessing other people, other peers providing services in different countries has always been, in my experience, a great learning opportunity. So witnessing the fact that you can actually do this, and it's not so difficult to do, keeps us strong in our motivation to continue advocacy, which we do not have to lose, because change takes time. And advocates for harm reduction need to continue fighting and not lose their hope and the motivation that they have in the harm reduction policy and the belief they have, because we will need to continue fighting on this field.
Thank you.
If I could just add to that, I think when you're looking at, especially in developing countries and countries with dramatically more limited resources, yes, on the one hand, harm reduction can be expensive to the extent it requires providing basic services to people that societies and governments have a hard time affording. On the other hand, when we go back to the basic idea of harm reduction as pragmatism and respect for human rights, what you begin to realize is that punitive prohibitionist policies are oftentimes quite expensive. It costs money to rely heavily on police and jail. It costs money to demand abstinence among people who are not ready to be abstinent. And conversely, the basic norm of treating drug users as basically as human beings who do not deserve to be discriminated against or punished simply because of their drug use, that's an effectively inexpensive strategy, right? Allowing people, all sorts of basic things of just getting the state out of the way so people can operate in their own self-interest and protect their own behavior. Many elements of harm reduction, in fact, will save governments substantial money at the same time as they save lives and reduce disease.
Excellent point. Anyone got anything to say on the specific point about tobacco harm reduction in sub-Saharan Africa? I will confess it's not an area that I have a great deal of knowledge on.
I think a lot of the principles are going to be the very same as you'd have anywhere else. I mean, what is a very pragmatic approach to take? What is it people are doing? What's available in terms of reducing the risks? What are the policy options that you need to have available for them? So, places that are banning alternatives, or making them far harder to get, or misinforming the public, it's the same problem as you have anywhere else. Meeting the needs of consumers, you've got a very entrepreneurial part of the world. Give people the ability to meet consumer needs with lower risk products. Why aren't we seeing, in some of the countries where oral tobacco is already established, why can't we see low risk oral tobacco products? They exist. They're really inexpensive to make. They're much cheaper than cigarettes to make. How do we create an incentive for that and for more entrepreneurial activity to meet needs with products that don't kill people?
I think we also have to be aware of where harm reduction and drug law reform intersect, so that when one looks at what South Africa did over the last few months in banning both alcohol and tobacco products, all tobacco products, I believe, and they were introducing a prohibitionist policy. And what we know about prohibitionist policies is that they can be successful, especially in their earlier periods, in reducing cumulative use. But they rapidly generate all sorts of prohibitionist harms: black markets, more dangerous products, diversion of law enforcement resources to try and stop black markets, and all this sort of thing. And I think we saw in South Africa that with the prohibition of cigarettes, that you began to see these illicit markets and people engaging in more dangerous activities and COVID risking activities in order to obtain cigarettes from sources which were no longer easily available. So, when we talk about tobacco harm reduction, we hope that sufficiently robust tobacco harm reduction policies will ultimately drive down the consumption of cigarettes, of combustible tobacco products, dramatically. There's every reason to believe they would. But at the same time, the basic principles of harm reduction should say that no matter how successful we are in driving down combustible tobacco use, we still should stop use of banning the sale of these products to adults.
There's one other question that I have here. It's more an observation, actually, which may resonate with some of us, about harm reduction isn't quite the same as preventing or controlling. Preventing or controlling are the two most commonly used by policymakers when they're attempting to address a way to end or combat a disease. And I certainly think although I would add it, actually, in the UK, when we talk about drugs, we seem to have an addiction to talking about tackling drugs. We like to tackle drugs. But the preventing or control, and perhaps harm reduction doesn't lend itself perhaps in the same way as you were talking about earlier, Ethan, to that sort of phraseology. Doesn't necessarily make good speeches.
I'll tell you, sometimes I hear people sort of contrast tobacco control with tobacco harm reduction. And I resist that sort of definite labeling it that way. I tend to see that we're all involved in tobacco control, and there's a harm reduction approach to tobacco control, or a harm reduction approach to broader illicit drug control, and a non-harm reduction, a punitive criminal justice absence-only oriented approach. So I see us really all engaged in trying to control the elements of these markets and the elements of these use. And similarly, when it comes to prevention, if people want to use that phrase, it's obviously the case that if you can, reduce the number of people or prevent people from getting involved in a risky activity in the first place, that's generally going to be a good thing, so long as they don't substitute other dangerous activities for it. But what I really tend to focus on is not so much preventing the use as preventing misuse. So if people are going to engage in activity, let's try to prevent the more risky elements of that activity. Let's try to reduce the more dangerous elements of that consumption. And I think that's a way of not getting so caught up in like prevention versus harm reduction, control versus. It's really about understanding that there's a harm reduction approach that cuts across the board.
Yeah, if I can just say, I've written various papers on this over the last 20 years or so, and I think that anytime you find any cause of death, injury, or disease, logically, there's just 4 ways to deal with it. You do things to try to get people to never engage in the activity. You do things to get people who are engaging in the activity to stop. You try to protect third parties from the hazards of that activity. And you do things to reduce the risk for people who are still going to deal with it. And it doesn't matter what the topic is. You look at all of those things and decide pragmatically what's the most effective way to do it. So, David, if you said that you're really keen on paragliding, I might say don't take that up. It's really dangerous. Have you tried chess instead? If you're already doing it, I might try to dissuade you from doing it. To say, have you tried road biking? How about you just stop paragliding for a couple of weekends and see how you are? If you're still going to be doing it, I say, can you try to do it in a place where you don't crash into other people? And if you insist you're going to do it, I might say, based on all the research I can see, this is the safest place to do it. And here's the equipment you should be wearing while you're doing it. And we do that on everything, whether we're talking about sporting activity, we're talking about automobile use, we're talking about drug use, we're talking about sexual behavior. We're trying to figure out what can we do to most pragmatically reduce risk where we find it.
Yeah, that's a really powerful analogy. I think we're coming to the end of the questions there. Heard a lot in there about compassion, the importance of evidence, an awful lot on pragmatism. But I think Cinzia's point particularly resonates, I think, with me on the fact that we need to carry on fighting, because even in countries where we think we've got advanced policies, we still need to push further on them all the time. But thank you very much for taking those questions, and thank you very much for your presentations.
Well, thank you for having this conference.
Yeah, and to be at one of these conferences and not be jet lagged. Thank you.
Thank you.